I thought those talks were superb. I just wanted to clarify one thing about angiosomes, which you probably all are fully aware of. Each angiosome is fed by a source artery, but each source artery is connected to one another by arterial-arterial bypasses. So I don't think it much matters whether you bypass the source artery or you bypass an other artery that has arterial-arterial connections to the artery where the angiosome is. And Varela's data shows that there's no difference if you bypass either the source artery or another artery with arterial-arterial connections. The problem comes when there's no connections to the angiosome where the ulcer is. And that often happens in the heel where the PT and perineal are out and the arch is incomplete. So for those are the problems. And so I don't know where you get such a high salvage rate. Ours is, I mean, there's one published study from Deaconess showed 85% salvage rate with DP bypasses for heel ulcers. So that's the problem for us. And what does endo do for those patients?
Could we kill the video first? Hello? Mike? Mike, yoo-hoo. Can we kill the video? Or you're doing it just down here? Thank you. We got multiple screens going on. We're playing video games down here. I look upon angiosomes as a prognostic indicator. I don't see them as, we're going to choose the best target from a surgical point of view. I'm just wondering what other people think about that. Darren? Microphone on here?
Yeah. So I agree completely with what you said. I mean, I think that there's been a lot of interest in angiosome-directed therapy. A little bit of it's a gimmick because it tends to be an argument in support of endo, because you can argue that you can reopen multiple tibial vessels and try to target with catheters specific angiosomes. I do think, like in that case that I showed with that retrograde pedal loop technique, that there we're opening up basically digital arteries to the fifth toe, and that would be hard to do surgically with bypass. So I think that endovascular techniques do lend themselves to doing some more of these small in the foot kind of interventions to try to build the collateral network. But I agree. We'll target the angiosome if we can. If we can't, we're still going to try a revascularization in the effort to get the foot better. And like that last paper that I showed regarding angiosomes, that it may be more whether or not the collateral network is intact in the first place. And so that's why it seems that it may be more important than an angiosome is whether or not you have an intact pedal arch and the connections between the different angiosomes.
Since you showed, we saw the slide, Rashid's paper, on his papers on the pedal arch. We did a study many years ago on this, and we found that the pedal arch is present as a complete arch in less than 2% of cases. So I don't know how he got those numbers. I personally believe that bypass graft to the lower extremity is bypass grafts to isolated segments. I think that Mike Belkin did a nice paper on isolated tibial segments, but I think it's the same thing in foot vessels, and I'm wondering what you all think. How about you, Frank?
It's, I think, a little bit of a misleading concept in the sense that it probably derives from the concept of dermatomes. And dermatomes are permanent. You're born with them, you die with them. But not so with angiosomes. You're born with them, you get atherosclerosis, and then the whole picture changes. So I like the idea of, first of all, you have to have an artery you can work with, whether it's endovascular or direct bypass, and that provides the best perfusion of the lesion. And that may not actually be the original angiosome artery, it's some other artery. So I don't know how valuable it is, and there is that thing about the dermatomes and the suggestion that these are equivalent. They're just not.
Any other comment on that? Mike, I'm wondering if you might give us some more thoughts on, since you alluded to it, mechanism of failure of these endoluminal devices. Covered stents, obviously, we're going to go down different ways than, and take collateral with them as opposed to bare metal stents and so forth. Could you comment on the mechanism of failure of these devices?
Yeah, so, it is a little different for covered stents and uncovered stents. A covered stent behaves more like a fem-pop bypass with prosthetic that's done internally. It fails due to intimal hyperplasia at the ends primarily. But fem-pop bypasses with prosthetic also don't do that great in comparison to other alternatives. So I think you have to think about it in that light. The problem with it is that, like prosthetic bypass grafts, when it goes down harder than a vein graft. In this case, potentially because of coverage of collaterals, but even the extension of thrombus in prosthetic compared to vein is very different. It tends to extend a little bit beyond into the native arteries. So I think they go down much harder. Bare metal stents don't frequently go down quite that way. But the problem is that there's a never-ending chronic inflammation related to the implant. So as opposed to plain old balloon angioplasty, where you have an injury at one moment in time that runs a course that may or may not reach the nose, and then the course is over, a bare metal stent is a permanent implant. And in the leg, where you also have motion, there's a chronic recurring injury that goes on there. It never goes away. It's like having a pebble in your shoe. And so I think they are different. I still believe that if we can get away from implants, particularly as we get into the vessels down in the popliteal and beyond, it would be better.
Thank you. Microphone.
I'm Jackie Ho from Singapore Vascular Surgeon. Thank you all for the very insightful talks. My question is about the Wi-Fi classification. I think this is a very thoughtful classification, including much more factors affecting the critical limb ischemia. But what I would think is in tumor surgery, when they have a TMM classification, the survival is more on simply whether the disease is clear surgically or not. But in critical limb ischemia, there are much more variables. Even like revascularization is a spectrum. It's not yes or no. And also for the aggressiveness of infection control and also tissue healing is a very wide spectrum and involve a lot of different technologies as well. So I don't know what all these factors would eventually affect the outcome and the amputation or the limb salvage rate. So I would like to know Dr. Mill and all the panel's opinion on this.
I think that's true, but the point is to try to get some classification system that at least includes the significant limb variables that you have to look at, so that when you compare therapies, the problem we're at now, bypass works on lots of patients, but endo actually works on more patients than you'd think. So when you're trying to figure out, what am I going to do with this patient, how do you compare your results if you don't have some starting point? So TNM, the analogy I would use there is when I trained, lots of women got mastectomies for breast cancer. It turns out that that's not necessary for most patients, and most patients now get something a lot less. So as the therapies change, it allows you to compare a different therapy in a roughly similar patient group. That's the main focus of that. Of course, to treat the patient, that's where I put the three circles. So the Wi-Fi is just the limb status. You still have to look at the patient. Then at some point, once you decide you're going to treat them, then the anatomy becomes important. So I'm not ignoring anatomy. But the problem with our current focus is it's device-driven, industry-driven, and it's lesion-driven. And you don't need to just treat the arterial lesion. It's much more complicated than that.
Before you comment, and we're going to let Mike's comment be the last, I would just like to, I was just wondering what's going on in this very minute in Frank LoGerfo's head when he didn't see neurobiology and neuroinflammation in Wi-Fi. Maybe that's the next iteration, Frank. Mike.
I was just going to point out that I think your question is less about classification and more about outcome measures. And I would agree, and I've written some things about outcome measures. I don't really like them that much, because I think we have a ways to go. And what I've particularly the point is that this is a chronic disease. It's more like heart failure, and patients move in different states of health or illness throughout the course of treatment. So all these slides that we show that show the time to the first event are really not anywhere near the whole story for the patient. The whole story for the patient is the area under the curve for 2 years of how many reinterventions and how many times they got a recurrent ulcer and how much pain they had. And if you want to look at the impact of care based on how they started, you have to look at the whole time average health state, limb-based health state for the patient, and we're not doing that at all.
So we're doing all this Kaplan-Meier stuff that really is kind of, it's the tip of the iceberg in these patients. I think if we combine better classification with a more universal way of looking at outcome, we'll finally start to figure out what actually is helping patients.
Well, with that comment, thank you very much, panelists, for an outstanding series of talks and panel discussion. Thank you very much.